We're going to continue on with our presentations this morning. So it is my pleasure to introduce Dr. Titilope Oduyebo. She will provide an update on the most recent pregnancy guidance. Dr. Oduyebo is an obstetrician and gynecologist, and throughout this Zika response, she's been my partner in crime. She has been the clinical team lead for the Pregnancy and Birth Defects Task Force. So she's been involved in writing all the clinical guidelines for Zika. And what's most amazing about Dr. Oduyebo, obviously I feel very proud of her, is that she came straight from her EIS experience. So EIS is the Epidemiologic Intelligence Service, and she left the Epidemiologic Intelligence Service and came straight into Zika, and as I said, has been by my side the entire time. So I'm really pleased to introduce her. She led the development of the most recent updated guidance for pregnant women and also the first guidance for pregnant women. So my pleasure to introduce and welcome Dr. Oduyebo.
Thank you for that kind introduction, Dr. Maggie Delman. So good morning, everyone. I'm here today to speak with you about the updated interim pregnancy guidance and discuss the implications for the evaluation and management of infants with possible congenital exposure to Zika. I'll first start with an overview. I will briefly summarize the rationale for the updated guidance and discuss the implications for the evaluation and management of infants with possible congenital exposure to Zika virus, and then discuss by discussing the steps and why we're all here today to address the potential gaps in identifying these infants. In the first session, Dr. Fisher and Dr. Kunert discussed in great detail the current state of the epidemic and the emerging data of the Zika test that has prompted the guidance updates. I'm going to briefly summarize some of those key points. First, the epidemiologic data shows a declining trend in the reported cases of Zika infection in the Americas, which leads to a lower pretest probability and a higher probability of false positive tests. Second, the Zika serologic tests do not reliably determine if and when an infection has occurred. And this happens for various reasons, which Dr. Kunert went through. But most importantly, there's been unpublished data that shows that Zika IgM can be detected for a prolonged period of time, and so unable to distinguish between a recent infection, meaning an infection that occurred during the current pregnancy, versus a past infection, an infection that occurred prior to pregnancy. In addition, the duration of the Zika IgM antibodies is unknown, as I just discussed, and also inconsistent. Last, as Dr. Kunert talked about, the timing of when the test is performed is very critical. Even though there are data out there showing that Zika IgM and also RNA can be detected for a prolonged period of time in different body fluids, the IgM wanes over time and Zika RNA is only transiently present in body fluids. In addition, the changing epidemiology, as Dr. Kunert discussed, further limits the diagnostic capability of the currently available tests. In light of the emerging data, on July 24, 2017, the CDC updated its interim clinical guidance for healthcare providers caring for pregnant women with possible Zika virus exposure. The updated guidance emphasizes a shared decision-making model for testing and screening of pregnant women, one in which the patients and providers work together to make decisions about testing and care plans based on the patient's preferences and values, clinical judgment, and a balance of the risk and expected outcomes. During this process, the healthcare provider's clinical judgment is imperative, and the decisions about whether to test, to advise testing, should be informed by factors, some of the factors listed on this slide, which include the length of possible exposure, the type or location of travel, intensity of Zika transmission, the presence of symptoms concerning for Zika, prevention measures taken while in the area with risk of Zika, the patient's preferences or concerns, as well as the jurisdictional recommendations. The testing recommendations in the updated guidance differs by the symptom status. There are now two algorithms, one for pregnant women with symptoms of Zika virus disease and one for those without. On this slide is an image of the algorithm for symptomatic pregnant women. Each of the algorithm begins with a reminder for healthcare providers to ask patients about possible exposure to Zika before and also during the current pregnancy, whether they've had a previous diagnosis of laboratory-confirmed Zika virus infection, as well as whether they currently or during the pregnancy had symptoms concerning for Zika. Before deciding whether to test, we have included a prompt for healthcare providers to discuss the limitations of the testing and the potential risks for misinterpretations of the results. On this slide is the image of the algorithm for the asymptomatic pregnant women. The recommendations for this group differ based on the circumstances of the possible exposure to Zika. The left arm of the algorithm contains guidance for testing asymptomatic pregnant women with ongoing exposure, which right now is defined as they currently live in or frequently travel to an area with risk of Zika. The right arm contains guidance for testing asymptomatic pregnant women without ongoing exposure. In the updated guidance, testing is recommended for symptomatic pregnant women as soon as possible through 12 weeks after symptom onset to diagnose the cause of their symptoms. Concurrent testing by nucleic acid test or NAT on serum and urine and serology on serum is recommended. For asymptomatic pregnant women with ongoing exposure, Zika virus should continue to be offered because these women are at continued risk of exposure during the pregnancy. The recommendation is for NAT to be offered 3 times during the pregnancy. Zika virus IgM antibody test is no longer routinely recommended for this group because of the emerging data, as Dr. Kruner eloquently discussed in the first session, about the emerging data indicating the challenges in determining whether a positive result represents an infection that occurred during this current pregnancy versus prior to conception. Last, for the asymptomatic pregnant women without ongoing exposure, Zika virus testing is not routinely recommended. Testing should be considered using the shared decision-making model that are informed by the factors we went over in a couple of slides earlier, as well as the jurisdiction recommendations. The jurisdictional recommendations may take into account the epidemiology of Zika virus transmission, as well as other epi factors and considerations in areas where there is risk for Zika, and therefore might include recommendations to test asymptomatic pregnant women as part of clinical care or surveillance, part of Zika infection surveillance. And we are aware of some state and local health departments that continue to test pregnant women right now and potentially reevaluate after mosquito season. We acknowledge that the updated recommendations will likely reduce the routine testing of asymptomatic pregnant women with possible exposure who do not have the ongoing exposure and have implications for surveillance information from this group, as well as the identification of infants with congenital Zika virus infection that may not have the phenotypic abnormalities. To address this, the task for this forum is to review, and that's for all of you, the think tank in this room, to review the emerging evidence and to obtain your individual input from all of you as SMEs on the diagnosis, the evaluation, and management of congenital Zika virus infection, and to explore the strategies to enhance communication and coordination of care. Now I'll turn this over to Dr. Sonja Rasmussen, who will provide a review of the emerging data on clinical findings and diagnostic testing, as well as CDC's recommendations for infants with possible Zika virus infection. Dr. Rasmussen is the director of CDC's Division of Public Health Information Dissemination and the editor-in-chief of CDC's Morbidity and Mortality Weekly Report. She was the lead author of the May 2016 special report in the New England Journal of Medicine, which established Zika virus as a cause of microcephaly.
Thanks, Titi. It's my pleasure to be here today to talk to you about Zika and infants. And I'm going to be giving some background that I know a lot of you are pretty familiar with, but as Dr. Mini Delman said at the beginning, we really are trying to make sure everybody's on the same page as we start our discussions. So I'm going to begin by talking about the clinical findings of the congenital Zika syndrome. And as many of you remember, about a year ago, a paper that Dr. Cindy Moore published in JAMA Pediatrics summarized the characteristic findings of congenital Zika syndrome. And we feel that this is a recognizable pattern of defects that are made up of these 5 characteristic findings: severe microcephaly with partial skull collapse, intracranial calcifications, primarily in the subcortical region. Of course, other infections have calcifications as well, but these are in a more distinct area. Macular scarring and focal pigmentary retinal modeling, congenital contractures, and neurologic abnormalities, including marked early hypertonia and symptoms of extrapyramidal involvement. So I'm just going to go through each of these briefly and then move on to some of the newer associated findings, newer findings that may be associated with congenital Zika infection. So first of all, the cranial morphology. Many of these kids have severe microcephaly, sometimes more than 3 standard deviations below the mean, and partial collapse of the skull with overlapping sutures. And as many of you remember, this is really a distinctive phenotype and helped us to identify Zika as a cause of microcephaly and other serious brain defects. There is also, and I'm going to try this, but it's always dangerous. So there's, you can see the overlapping sutures here. You can see the occipital bone prominence here. And then many of these kids, because of that overlapping sutures, can have a small or even absent anterior fontanelle, and you'll hear how that affects trying to get a brain ultrasound later on. Also, many of the kids have scalp rugae. You can see that here. That's because the scalp was really growing for what was anticipated to be a bigger brain than it ends up being because of the collapse. This is consistent with something called fetal brain disruption sequence. And this is a phenotype that is not seen with all kids with severe microcephaly. In addition, although it's rare, there were about 20 case reports published in 2001, a summary of 20 case reports that was published in 2001, so it's really pretty rare, but it's not unique to congenital Zika syndrome. Now, the brain anomalies, there's typically a thin cerebral cortex and intracranial calcifications, primarily in that subcortical region, and you can see here. There's hydrocephalus and hydrocephalus ex vacui. I'm going to talk about that a little bit later. Hydranencephaly, gyral abnormalities, particularly polymicrogyria, absent or hypoplastic corpus callosum, and then hypoplasia of the cerebellum or cerebellar vermis. There are also ocular findings. Early on, some of the reports were of anterior eye anomalies, microphthalmia, coloboma, cataracts, etc. But really, most of the findings that of the ophthalmology papers recently have really focused on abnormalities of the retina, optic nerve hypoplasia, atrophy, chorioretinal atrophy and scarring, macular pallor, and then those pigmentary anomalies, especially in the macular area. Of note, there hasn't been any active chorioretinitis reported. And then congenital contractures, and here you can see 2 babies with contractures. These contractures can be a single joint or multiple joints, arthrogryposis. They can be large joints, small joints, upper limbs, lower limbs, or both. There have been several reports of kids with hip dysplasia. Contractures have not been previously associated with fetal brain disruption sequence phenotype. And contractures have been seen with other infections, although those are not very well documented. There are some reports of spinal cord hypoplasia in infants with the contractures, and that may be the pathogenesis of these contractures. So I want to talk a little bit now about some of the other findings that have been more recently identified as possibly associated with congenital Zika syndrome, because I think it's important for us to consider those today to determine if that's something that we should be letting healthcare providers know about so they can consider it in their evaluation of kids with congenital Zika infection. So one of the things that we've known about for a while, this is again a paper that Dr. Moore was involved in with Dr. van der Linden from Brazil. This was findings of postnatal onset of microcephaly, and these were kids that did have brain or eye anomalies, but they did not have microcephaly at birth. And this is one of the points early on where we really were thinking microcephaly had to be there, and of course now we realize that's not really the case. These were kids that did not have microcephaly at birth, but later on the head growth slowed and microcephaly was diagnosed at about 6 months of age. it's important to note that these kids did have significant brain anomalies, and some had retina anomalies too. And this is one of the reasons why in our previous recommendations, we did say that kids with moms who had had infection should have head ultrasounds, because we think they need to have that imaging early on. Another thing that's been seen more recently, and a full report on this has not come out yet, but we have some information from Dr. van der Linden in Brazil about postnatal onset hydrocephalus. So these are kids whose moms were exposed during pregnancy. So this is, again, due to congenital infection, but they're developing later onset hydrocephalus. And this is information from a chapter that Dr. van der Linden wrote. The full report of this has not come out yet. But these kids are developing hydrocephalus at 3 to 12 months of age. The clinical symptoms were nonspecific. The cause of this hydrocephalus is unknown, but it is increased pressure hydrocephalus that requires shunting. And so in the chapter, Dr. van der Linden talks about considering brain imaging for hydrocephalus at 10 to 12 months of age, or in the presence of clinical deterioration. So this is something I think we need to think about, whether this is something that's needed. There also have been some EEG abnormalities in infants without recognized seizures. Of course, there's kids with recognized seizures that have EEG abnormalities too, but this report is some kids that did not have any recognized seizures, but did have laboratory confirmation of Zika virus infection and microcephaly, who had sleep EEGs that had abnormalities. And so I think it's another thing that we should consider. I'm not sure of the clinical significance of this, but I think it's something we need to think about, especially in the blue team group. Then there's isolated eye findings without microcephaly. This is a paper that was published online last month by Zinn and colleagues, and it was 112 infants born to moms who were symptomatic, who had PCR-confirmed Zika virus infection. It's important to note that there were 24 kids that had eye abnormalities, but the infant testing was not performed. And as we've noted before, optic nerve and chorioretinal abnormalities were the most frequent findings. 10 of the infants that had eye findings did not have microcephaly, and 8 of them didn't have any CNS anomalies. 2 of those 8 infants had transient hemorrhage only, and whether that's associated with Zika virus infection, whether these kids even had Zika virus infection is not known. 6 of the 8 had the remaining defects. They had optic nerve anomalies, as we would expect, pigmentary anomalies, and then microphthalmia. We've known from early on that kids with congenital Zika syndrome can have dysphagia, and this is a study looking more carefully at that dysphagia using fiber optic endoscopy. And 8 of those infants had significant problems with their delays in initiation of the pharyngeal phase of swallowing. So whether swallowing studies are going to be helpful, I think, is another thing that we need to think about in our group. Another thing that's been identified is unilateral diaphragmatic paralysis, or at least the 4 reports that have been published have been unilateral. These have been in kids with congenital Zika syndrome, presumed congenital Zika syndrome, and with arthrogryposis, interestingly. And they presented with respiratory distress or respiratory failure. All have been right-sided in the reports, in the 4 reports that have appeared. And this is another thing that we may want to consider letting pediatric healthcare providers be aware of, that if they have a child that presents with respiratory distress. There have been elevated liver enzymes. This has been in 2 different papers. One is actually blood sampling from symptomatic fetuses, and they have been elevated liver enzymes. There hasn't been other studies, as far as I'm aware, of the liver problems. And this is similar to what we've seen with other infections, so I don't think it's really a surprise. It is something that we did include in our previous recommendations for kids with congenital Zika infection. Is measuring liver enzymes. And then growth restriction, I think, is something that is not answered at this point yet, whether growth restriction is associated or not. This is a paper from Dr. Brasil from Brazil, which is always confusing. But there were 117 infants born to Zika virus positive mothers, and nearly 10% of them were small for gestational age, compared to 5% of the moms in their cohort that was Zika virus negative. So whether, of course, small for gestational age, we usually think of it being about 10%. So whether growth restriction is part of congenital Zika syndrome or not, I think is not answered yet, although I don't think we'd be surprised if it was, given that it has been associated with other congenital infections. And then finally, what about other birth defects like congenital heart defects? So most of what we know of have been things related to the brain and the consequences of the damage to the brain. What about other types of birth defects? And this is a study that looked at echocardiography of 103 infants with presumed congenital Zika syndrome, and using an echo on every one of these kids. The kids in advance didn't have any signs of heart disease except one child that had dyspnea. And there were 14 of those 103 echoes that were compatible with congenital heart defects. However, they had really generally mild congenital heart defects, similar to what you see if you do echoes on a lot of kids. So there were 5 with secundum ASDs, 8 with small apical muscular VSDs, which those of us who've worked in a NICU know you see a lot of those if you do a lot of echoes, and those are hemodynamically insignificant. And then the one child that had dyspnea had a large membranous VSD. So the rate of congenital heart defects in this population was 135 per thousand, fairly close to the 1% that we see in the general population anyway. So I think this is, again, an unanswered question, although I think right now, certainly this study makes me think that, at least in the numbers that have been looked at, that congenital heart defects are not a big issue in congenital Zika syndrome. So now I'm going to review the current guidance for evaluation and management of infants exposed to Zika. And many of you participated in our previous meeting that we held in July of 2016, where we put together the bulk of this guidance. Again, this was a meeting that was in collaboration with the American Academy of Pediatrics, and many of you were here at that time. And that was published in August of 2016 in the MMWR. And then as additional information became available, we did provide an update to that August 2016 guidance. We provided new considerations, which we just released on the internet, and then again after the new pregnancy guidance in July 2017. So I'm going to review all of that quickly here so everybody knows where we're at now before we think about where to go in the future. So the recommendations for who to test, which infants to test for possible congenital Zika virus infection, recommended for infants born to mothers with possible laboratory evidence of possible Zika virus infection, and then infants with findings suggestive of congenital Zika syndrome with a maternal epidemiologic link suggesting possible transmission, so either moms who have been living in or are traveled to an area with transmission of Zika, or someone who's had sex without a condom with a partner who has traveled to or resided in such an area, regardless of the maternal testing results. And that relates to some of the issues that Dr. Kunert talked about earlier today. Laboratory testing for Zika virus infection should also be considered for infants born to mothers with an epi link to an area with the risk of Zika who are not tested at all. Then mothers with negative testing but who have ongoing maternal Zika virus exposure. And then infants whose negative testing was performed really what we think of as outside of the range, so after 12 weeks, where we think that the IgM might have waned. So this is from our additional considerations. We began hearing from people in the field that it was difficult sometimes to get that testing done in the first 2 days of life, and whether it was worth doing testing afterwards. We would actually prefer people do testing in the first 2 days after birth, but if it's not possible, we wrote that specimens collected within the first few weeks to months after birth may still be useful for evaluation. And this is especially for infants born in areas without a risk of Zika. If you're in a place where there's continuing transmission of Zika, it's going to be difficult to tell if that's a postnatal infection, an infection after birth, or something that a congenital infection. We also began to see some reports in the literature of kids that where cerebrospinal fluid, where CSF was the only sample that was testing positive. And so and we've also heard some anecdotal reports. The published reports were from Brazil. The anecdotal reports we've heard, actually some from the US, where there have been negative results in serum and urine, but in kids where there's been signs of congenital Zika syndrome. So in that update, the additional consideration we said is to consider obtaining CSF for Zika virus RNA and for IgM antibody testing in infants with clinical findings of possible Zika, congenital Zika syndrome, but for whom initial lab tests are negative. So then, as many of you recall, in that first set of guidance that we did in the July meeting, published in August, we divided into babies with abnormalities and then without abnormalities, and then you test them, and then with laboratory evidence and without. So for infants without lab abnormalities born to moms with laboratory evidence of Zika virus infection, they receive mostly routine care, comprehensive physical exam, a neurologic assessment, standard newborn hearing screening, but we did recommend everybody receive a postnatal head ultrasound, and that's because of some of the evidence of some kids not having microcephaly but having brain anomalies. Also, Zika virus lab testing was recommended for those kids. For those moms that are in that more iffy, either without testing outside the window, or people with possible maternal Zika virus exposure that's ongoing, we, in addition to those standard things, the comprehensive physical exam, the neurologic assessment, and standard newborn screening, we stated that the provider should consider whether further examination is warranted with postnatal head ultrasound and an eye assessment. And that's, of course, because there are possible ways to intervene if there are problems with the eyes recognized. And then considering Zika laboratory testing in the infant based on the results of those evaluations. So now switching to babies who at birth are noted to either have microcephaly or other findings associated, consistent with congenital Zika syndrome. We recommended really a quite complete, I think, a comprehensive workup. In addition to the routine newborn care and head ultrasound and testing for Zika, we recommended a CBC, metabolic panel and liver enzymes, consult with multiple subspecialists, and that was depending on what the child presented with. For example, with contractures, you would get an orthopedic evaluation, an eye exam by an ophthalmologist, an auditory brainstem response, hearing, and then considering advanced cranial imaging and considering transfer to hospital with specialty care after discussing with the family about their desires of, certainly it makes all those specialty evaluations easier. One of the things that we added in our additional considerations is that we were hearing that there were a lot of kids with small or really an absent anterior fontanelle, and the ultrasound was not showing enough of the brain to be able to tell if the child had problems or not. And so for those, we stated that other imaging, such as MRI or CT, should be considered. Now for outpatient management, that was primarily when you see the kid in the hospital. Now we're moving to outpatient management for infants with lab evidence of Zika and without abnormalities. So they've tested positive with Zika, but they look well. We want you to establish a medical home, an eye exam by 1 month of age, as mentioned before, because of the importance of visual screening, and then vision screening at every well child visit, and then evaluating hearing, ABR by 1 month of age, considering repeat ABR at 4 to 6 months, or behavioral diagnostic testing at age 9 months if the ABR is not done, and then age-appropriate developmental exams at each visit, and referrals as needed, and of course family support services. Now this is that group that has lab evidence of Zika and with abnormalities consistent with congenital Zika syndrome. Again, establishing a medical home, routine pediatric care, including all their shots, and monthly primary care visits for the first 6 months, developmental monitoring at every routine visit, and referring patients to a developmental specialist and early intervention services, that complete neuro exam at 1 and 2 months, an eye exam with retinal assessment again at 3 months, ABR hearing assessment at age 4 to 6 months, thyroid screening, and providing family support services and appropriate referrals. And now we're with the group that has some evidence that you think they might have congenital Zika infection, but for whom the lab evidence is lacking. So the lab testing is normal. We recognize that there are issues, and we've heard a lot about those issues today with the laboratory testing. We recommended evaluation for other causes of congenital infection because some other infections, particularly CMV, can look fairly similar to congenital Zika. Considering an ophthalmologic exam and ABR hearing testing before hospital discharge or within 1 month of birth. And then consider performing the other evaluations and follow-up care that are recommended for congenital Zika syndrome. So the tasks for today, so that's where we're at now, and then now we're going to figure out where we're going to go in the breakout groups this afternoon. The primary group of interest that we're looking for individual expert input on is newborns and infants without signs of congenital Zika syndrome. You've heard that we've done a fairly, I think, comprehensive job of those kids that have abnormalities at birth, but what do we do with the kids that don't have any signs of CZS, that are born to moms for whom Zika virus infection cannot be ruled out? And you've heard about the reasons why it might not be able to be ruled out. So should they get laboratory testing? How do you address that maternal history? What if the mom has just been in a country with fairly low levels of transmission for a short amount of time versus someone who's living there and being there for a longer period of time? And then what kinds of infant screening and evaluation needs to be done and at various times after the birth? The time must be up. The secondary group is for newborns and infants with signs of congenital Zika syndrome, and newborn and infants without findings, born to moms who are positive for Zika, so people who we have a higher level of suspicion for. We need to update that current guidance that we gave out. Is there information, for example, of those other possibly associated findings that we want to let pediatric healthcare providers know about? And then can we say something about that timing for after 1 year? We really, at the last meeting, only felt comfortable going out on a limb as far as 1 year, and do we have enough data to say anything for evaluation of babies that are 12 months of age or older? So thank you.
Thank you, Dr. Rasmussen. That was amazing, as always. Just a little tidbit. And when I first came to CDC, Dr. Rasmussen was one of the first people that I met, and she's been an incredible mentor of mine. She's taught me how to write. I aspire to someday be as good a writer as she is. So thank you again. Really appreciate it. It is now my pleasure and honor to introduce Dr. Miguel Valencia, who is a board-certified pediatrician and director of the Children with Special Health Needs for the Puerto Rico Department of Health. Dr. Valencia has been a close collaborator of CDC on the Zika response and has been truly, truly on the front lines of the response in Puerto Rico. I had the opportunity to go to Puerto Rico last week and meet with Dr. Valencia and see his incredible pediatric regional health centers, and I am just truly amazed at what this man has been able to do in a very short period of time. So with no further ado, Dr. Valencia.
I'm going to excuse myself because I have bronchitis for almost 3 weeks now, but I will try to do my best. Okay, I was asked to share with you my experience and the Children with Special Healthcare Need program role in the response to the Zika epidemic in Puerto Rico during 2016. We didn't know at the time that we created this new division that it would be our infrastructure for dealing with that epidemic and the families that would be affected by the Zika virus infection. So we decided to bring together all our programs that have to do with newborn screening. For example, at that time we had the birth defects. We have an active birth defect since 1996, and it was related to the use of folic acid and NTDs because we had a large prevalence or high prevalence on NTDs. So that's an active system. We also moved the universal newborn hearing screening, the regular newborn screening, and then we added the newborn screening for CCHD. After that, we tried to set up the system because we were ordered by law to have the pediatric centers as facilities for the identification, diagnosis, and treatment of autism. So we are building with a little money and mostly Title V money, trying to put these centers that were neglected for years, trying to put them back in shape. So we move the screening programs, trying to identify early on the children with special health care needs and have the system that will help those families to access the services through 7 regional pediatric centers and 2 autism centers. So when Zika came and there was the decision, well, we want to do different from the state. We have an active Zika surveillance system. So it made sense at that time to say, well, this would be babies with possible birth defects. So it should be integrated into this system. And that's the infrastructure. So our goal at the Children with Special Healthcare Needs is to provide and promote family-centered, community-based coordinated care, including care coordination for children with special healthcare needs, and to facilitate the development of community-based system services for such children and their families. And we know children born to mothers that were positive during pregnancy, they meet the definition. So this is our setting. Our health system is divided into 7 regions. Each star is one of our pediatric centers, is in the major municipality. So our goal is, before that, most families have to go all the way to San Juan, where is the red dot. It's our autism center in San Juan, and most of the specialties are there. So what we were trying to do is, families doesn't have to come all the way to San Juan, even though we are small. Transportation is an issue. So this is our setting. So we need core services. That would be a pediatrician. Believe it or not, these were pediatric centers without pediatricians. So we got some money from Title V, and they said, well, these will be our core services: the pediatrician, nurse, social worker, service coordinator, for doing screening, evaluation, service coordination, referrals, and family support. But then we'll say for Zika, we want to make sure that even though we have service coordination, you can bring the family, but probably the family cannot stay with you. So we want somebody to help families engage with the system, because we can plan the best system. Well, this probably works the best, but when families come in, they will say, well, this doesn't work for me, I probably will work for this. So we have to make system. We need that input so that the system that we are developing work for the families that we are trying to serve. And also we have these ones, the liaison coordinators. This is families that we know that are identified through the screening and the programs and the surveillance programs, but the phones, the addresses, doesn't work, so we have to go out to the community to try to find those families and bring them to the service. So these are new. So I just say that service coordinators facilitates the implementation of the developmental surveillance protocol that I will show later. It's kind of different from the recommendation from CDC in terms that it goes up to 3 years of age. So this is, for me, the staff most important now. This staff is mostly composed of families of children with special healthcare needs, and even among these families are families that were affected by the Zika virus during pregnancy, so they know what they are dealing with. So, and this one is the liaison that helps locate families and provide the follow-up who will us. So we decided, okay, now we need a secondary level of services to provide support. So that would be the psychologist, the special language, and there probably will be consultation and evaluation, because we didn't have the money at that time, okay? Because the money first came for surveillance, the money then came for kind of service coordination. The last money we got was from Zika MCH and the CMS grant, and that's where the money for services came. And that was December 2016 and January 2017. So we don't want to have the specialists in the centers necessarily, but we want families to be able to access those specialists. So we are trying to work that with service coordinator and working with the specialists so they can, families, we can do the arrangements and help them coordinate the services they need. In the Metro Clinic, we have some specialists that they are not available island-wide, But these are special clinics that the families are being seen by multidisciplinary teams. So, for example, we have the neural defects or the craniofacial. There will be a psychologist, there will be an audiologist, there will be a speech and language pathologist. And what we're trying, as long as we can do it, we can also want to have that in the other centers. So when the Zika MCH money, we say, yes, we have money. So we have been able to increase our workforce. We are getting equipment and supplies to provide recommended screening, diagnosis, and treatment care for all children with special healthcare needs, but mainly for families affected and infants born to mothers affected by Zika. We are moving to health information technology, including telehealth. Remember, I told you transportation is a problem, so we're going to start first with communications between the centers using telemedicine, so the patients, we have the specialist at the metro, they don't have to come to metro. They can stay in Mayagüez, and we can do telehealth. And also the electronic health, so we can, if they are seen in San Metro or they are seen by Bayamon, they will have the same record, and we can see everything, so that all the records will be shared within the program. Transportation services. Well, now we are learning from families what the transportation is. We put that in the grant, but we didn't know what specifically families need. So now that families are being involved, we are getting the feedback, and we are working on those services. And you probably may have heard, but our centers were not in the best shape physically, even though we have professionals that will work there. So we only got $150,000 from the MCH grant to improve our work centers, and we are working on that. That is the one in Ponce. But we are providing services there. Even when there was a federal visit from the MCH, we went there, and that day there was no even power. So they're working there without power, but the patients and families were being seen. So the CMS grant came in January 2017, and we are using that money, especially to make special contracts, because most of our families are with the government health insurance, and if you go with the pediatric neurologists, most of them won't participate on that one. But we have already contacted them, and they are willing to contract with the Children with Special Health Needs Program. So we are working around a contract with using the CMS money, so those will be available to all families. These are key. These administrative orders are key for us to do the work. On the one of September 357, we changed. We need when back in December 2015, I talked to the epidemiologist, and she asked me, do we have microcephaly under surveillance? And I say no. So we decided, yeah, we will begin in January 2016. Before that, then we decided, okay, we need to have a baseline prevalence before that. So we went back and checked all the records from different sources, 2013, 14, 15. And then I said, we had a problem. They're measuring in inches, and they're measuring 12, 12 and a half, 13. We are missing the 12 and 1/4. So it's not accurate, and we are going to have problems. Okay, so we decided that this executive order, all births infertility, now we have to start measuring in centimeters. Okay, and then all the 358, we need to identify these babies, and this is mandatory reporting. So anyone who enters in contact with a baby only have 24 hours to let us know that they are following that baby, or that they know about that family with that baby affected. And then we have all the 360. All families have to be offered the opportunity to come to our center for developmental surveillance and for coordination of services. Okay. So congenital microcephaly was included in the definition. Health circumference needs to be taken. And before that, it was not included in the information in the birth certificate. So from October 1st, now it's mandatory for the physician to record health circumference in centimeters in the form that they had to submit for the birth registry. And then we have the guidelines that we followed the CDC guidelines, but we went a little bit more what the guidelines were. I will show you that in a moment. Are these ones? So we want to follow all those babies since the beginning until they are 36 months. We want to be at the centers, come to the centers, because we knew that probably even in the primary setting with the primary provider, they were not getting the developmental screening because mostly it was an issue with getting paid for doing that. So we say we are going to cover that gap. Early intervention was not doing developmental screening. So say this is a gap that Title V needs to cover. So we decided that we were going to do it at the center. So that's one of the reasons. But the other one is that we decided that every infant, every family that had an infant born affected by Zika will have a service coordinator. And the reason is because we want to, on that first visit, we want to check. The other difference was we decided that we were going to have an eye exam in every baby born. It's not only on the positive one, but every baby born to a positive woman will need to have an eye exam during that first month. We changed, and we need to make sure that when they did the newborn hearing screening, they did it using ABR. If they use autoacoustic emission, then that baby should have an evaluation, not a screening, at 1 month of age using ABR. And then we will repeat if the baby has any anomalies, we will repeat the eye exam at 3 months. If the baby is okay, we will repeat that eye exam at 6 months. So this is the system that, let me just explain. All labs in pregnant women in Puerto Rico during the epidemic were run by the public health lab, either at the biochemical and chemical emergencies lab or the CDC dengue branch. So that means that we have access. And it wasn't in the executive order. If you're a practicing physician and you're ordering a sample to a pregnant woman, that sample has to be taken to Puerto Rico Department of Health. You cannot send that lab to the private because they didn't have the algorithm to run that. So that's the reason we in SAPS have the universe, we can say that, of all the positive results. And we can identify those women, and then we can follow them. So we have that in the race tree. So because we were working with birth defects, we had a good relationship with the maternal fetal medicine, especially Dr. Vega. Dr. Vega is one of them. So we share the information prenatally because the orders say that he has to let me know that he has already seen a patient that we changed or a normal ultrasound that changed possible related to Zika, so he will notify. Believe me when I say that sometimes he's just in the exam room with the transducer and with the phone. On the other hand, I say, Dr. Valencia, I have this case. I need the results if they don't have it, so we can have that relationship. But that allow us to, when they ask me, are we missing some baby that we are not getting it? So what we have been doing is, as soon as the baby is born, we try to get the ultrasound and we can provide them feedback and say, you didn't miss it. And if they got it right, yeah, you identify it. We are okay. So I think we are good, and I feel confident on that. So if a baby we don't identify through the lab and we follow, then we have the birth defect system because we are following the same defects with the birth defects independently if the baby was positive or not. So we can follow that, and all of them in the green line, you see infants with possible Zika-associated birth defects, they also refer to us. They doesn't have to be a baby that was born to a positive woman. So all of them with the same defects will come to our program for follow-up. Birth defects is also reporting. Our birth defect is active, so it will allow our abstractors to go to the hospitals, and if they identify a baby that was born and was from a mom that was positive during pregnancy, they will notify us. So those lines, what they show is the cross-communication between all the surveillance program, just trying to make sure that we don't miss a baby. And we can refer that baby for the services. Newborn hearing program, again, so it's within our division, so they keep referring to us the abnormal, we can say, well, I don't have the screening result for this baby, so I can check with them and they cooperate. What is missing there is that, I forgot, we also have an agreement with the demographic registry, and now my staff, let's suppose we are following a woman and say, well, she is already 42 weeks, and we haven't received a report that the baby is already born. So we can go into the demographic registry database and we can identify where that baby was born, so we can send our staff and do the extraction and then contact the family and refer the family to our service. So on this part, this is what we're doing, developmental surveillance screening, trying also to get more staff for providing the pediatric and family engagement and support services, the coordination of the services, and follow up until 3 years. And we do this in close relationship with the primary care providers. We don't want to take these families out of their primary care provider. We want to support them. Okay. In some cases, they say, well, you do it, let me know. In other cases, they want to do everything and let us know that what are they doing. Excuse me. And another big role is APNI. APNI is our Parent Training and Information Center. So they are working close with us. They are working with our family engagement to train them, just to make sure that we are doing what we need to do that really will help these families. So all those, the numbers, is the funding. So you see, blue one is more ahead than the green one, we can say that, because these are funds that we just received more recently. Again, surveillance, data gathering, service coordination is ahead because the funding were available earlier. So right now we are putting together all these, making contracts to make sure that services are available. I think that's it.
Thank you so much, Dr. Valenzi. I really, really appreciate hearing about all that great work. So I think we're going to open it up for questions for this session. Is that right, Paul? So we'd love to hear your questions. We have till about 11:30 before lunch, so love to hear your questions for any of the presenters.
This question is for Dr. Valencia. I'm Jim Bale, child urologist in Salt Lake City. What are your thoughts beyond age 3? I think we recognize that many of these issues are really going to carry on into probably young adulthood and maybe beyond. I'm curious to hear about like other key time points, maybe age 5, maybe age 12, beyond. What are your plans for the future for the evaluation for these infants?
You got to press that.
Yeah, remember these kids have been followed at the Children Special program, so they can be in the program until they are 21 years old, so we can follow them. So there should be no problem.
That's a really nice presentation, and I'm really impressed at the degree of follow-up that you're doing. I just sent Dr. Tate and Dr. Who else is in here? That someone else who's going to be following up these. Eric, Dr. Zivan. An article that just was published out of Stanford by one of our neonatology health services researchers, and what they found was looking at neonatology centers around California. We have a big network. There were noted pretty significant racial and ethnic disparities in care of preterm babies across California NICUs. And the differences across the state were not very big, but within NICUs, there were definitely racial and ethnic disparities just in care of infants. For example, Hispanic and Black babies were less likely to get steroids before delivery, et cetera. So again, these may be unconscious biases or lack of care. We don't know, lack of access. But I think it's going to be important for your groups when you come to these discussions to really talk about how to create templates for, and again, this was NICUs, but we also want to carry that forward because I think these are pretty substantial issues. And I think if you cost out issues around long-term follow-up, these are not only neurologic and healthcare outcomes, but there's also economic outcomes that really impact our society. So I really think that what you did there is great, but we really need to make sure that we get these kinds of templates very prescriptively sent out to as many people as possible, which I'm sure is the reason for this meeting. But that paper, I think, really highlights that there are, even with guidelines, disparities will still exist. Thank you.
Thank you for that comment, and I think we've seen what Dr. Valencia has done in terms of creating a template across Puerto Rico. I will say that when we started the pregnancy and infant registries, we were hearing from many of our partners that the surveillance variables that we were trying to capture, they wanted to turn them into a clinical protocol for what needed to actually be done. So I think there's definitely a need that I'm hearing, at least, for that. And it wasn't the intent, but it was utilized for that purposes in many regions. So I think it's interesting to see how both surveillance and clinical can come together and perhaps create protocols that obviously could be modified by jurisdictions. Sorry.
This is a perfect piggyback. I'm Chris Curry. I'm an OB/GYN at University of Miami and Jackson Memorial Hospital. And as we break into our groups, I wanted to provide a little bit of our contextual data when we're thinking about how you have interactions between provider and maternal testing with all of its caveats, as well as being good stewards of testing so that our pediatric colleagues have as much information as possible. And a few reflections. One, the barrier to testing from a costing standpoint is something that was addressed in Florida, and I wanted to share that the Florida Department of Health very early on decided to cover all of the testing, which became a huge benefit to clinicians because you could test without consequence to patient insurance. That is relevant to our patient population. 20% of our Zika positive moms had no insurance. 60% had public insurance. And so had we relied on private insurance and funding streams, many of our patients would not have been identified. And then piggybacking on the sort of social disparities, our patients were largely non-English speaking, which is both a reflection of Miami and a reflection of risk for infectious disease. The majority of our patients did not receive messages that were not in English, either Spanish or Haitian Creole being our predominant languages. And then the last reflection being on local modification for screening as sort of a way to address local issues. We made a decision in August of last year that if a woman presented to our labor floor having not been screened previously, that we would screen her at labor and delivery, which was sort of outside of the workflow nationally, with the idea being that our poor pediatricians needed some information. And a quarter of the women who had laboratory testing were identified with that labor and delivery interaction. The follow-up and loss to follow-up issues are certainly real and challenging, but in terms of giving providers that latitude to do screening, that was a really important intervention that we had not predicted. So I just wanted to lob those out there.
Thank you very much, Christine. Appreciate it. Other comments, thoughts?
David Kimberlin, University of Alabama, Birmingham. Can we revisit the sensory neural hearing loss and the ALT elevations? What proportion of affected babies have sensory neural hearing loss? Have we seen late onset SNHL? And can you describe a little bit more the kinetics of these transaminitis events?
First, the question about late onset hearing loss. We've really looked for these cases, and we were concerned initially because of the experience with CMV. We haven't really seen late onset sensory neural hearing loss. We have heard from our colleagues in Brazil that there have been some cases that have had conductive hearing loss identified later on, but not sensory neural. So that is reassuring. It's small numbers so far, but at least the information we have so far about that appears to be more reassuring. Cindy, do you want to say anything more since you've spoken with Dr. Leo?
No, just that we've not gotten those reports and we have talked to specialists down there who would be seeing those babies. And the number.
Thank you.
The number, I think, Is around 8%, 8 to 10%, that's been identified with sensory neural hearing loss as infants. I mean, initially, not delayed onset. I think you asked about how many babies and if we had seen that. And again, that's been in not large groups of babies, but that's the number I recall from the MMWR, isn't that right? And what was
And the transaminitis, the kinetics of the ALT and AST elevations?
I have not seen information about the kinetics of that.
Do we know how likely it is? What percentage had transaminitis?
We don't. I mean, none of these things have been studied in a systematic way, so we don't have that information.
Thank you.
Sure.
Yes, Fernando Isern, pediatrician from Puerto Rico. Just to piggyback on the economic issue, it's great that any state or jurisdiction that the state include all the necessary funding, but funding is limited. And some of these kids, not all, but are covered by the insurance companies. So it's important that if this were another disease, the insurance companies would be covering it, depending on the coverage, but that the state or the jurisdiction should bill the insurance companies for these tests, or should enter into agreement that this should be covered, especially the catastrophic part, because there's a tendency to say, this is something new, this is something I'm going to carve out, and this is going to be laid down to the state, and that taxes the already small amount of money that each state or jurisdiction has for children with severe congenital diseases. And if the parents pay for an insurance, the insurance company should be paying for that.
Thank you very much for that comment.
Hi, I'm Richard Dinella. I'm with the Minnesota Department of Health, and I represent CSTE. And I just want to make a comment rather than a question, which is we just did a poll 2 days ago of all state and local health departments that are involved. You know, we don't get a good sense about how much testing is done at state health labs versus commercial labs, but majority of testing is still done at state public health labs. And so we asked the question whether or not states have changed their prenatal testing guidelines to no longer offer testing for asymptomatic pregnant women. And 21 states did change their recommendations, no longer really offer, although there's still a shared decision-making and the exceptions will be made, but in general do not offer testing for asymptomatic, presumably exposed pregnant women. But most of those states are relatively rural, small states. Most of the large states have not changed their testing guidelines and still offer testing for asymptomatic, pregnant, potentially exposed women, including New York State, New York City, Florida. The only exception probably being New Jersey, which did change its guidelines. So just to get everybody on the same page, state health departments were still doing the majority of testing for pregnant women. Majority of them, I'd say, are still offering that test free of charge for pregnant women who are asymptomatic.
Dr. Dillon, can I just ask a question? Did you, in your survey of the various jurisdictions, did you ask if that would be reevaluated at any point after this mosquito season? Or because I think there was a concern, and we heard it loud and clear, that making a change in recommendations sort of
Right. So
during a mosquito season was challenging.
The concern over the change in the guidelines was sort of it's the middle of the busy travel season
Right.
for most people. So why would you change it now? And it also kind of coincides with the mosquito season. So most states, when it got changed, the pushback was, why don't we wait and reevaluate this? So I think most states are willing to reevaluate this.
But you didn't ask about it.
We didn't ask that, but I think for those that are still offering, I think those states would be willing to reevaluate it, say in 5-6 months from now.
Great. Thank you very much for sharing that.
Alberto La Vega from Puerto Rico. I do worry about the fact that as these babies are born, especially those that have no obvious abnormalities, and we continue to follow them from years to come, all of this will increase their health costs, which are currently being covered mostly by the states, etc., as it was said here. But we don't know that will be true for years to come. And these people will be classified as being born with a pre-existing condition, which may produce problems for them, even if they have no findings. So we run the risk with all these recommendations of doing that. Okay.
I think we certainly hope our surveillance data will help reassure us if we find less issues as time goes on. That's why these surveillance systems, I think, are so critical and so important, particularly in Puerto Rico. Sorry.
Scott Needle, Primary Care, Naples, Florida. Quick question. Last year, there were many reports that the babies being born with congenital Zika syndrome were very irritable. Was wondering if there had been any follow-up on that, if it dissipates with time, if it's been a trend that we're continuing to see, any follow-up information.
Yes, Cindy, do you want to comment on that since you've really been seeing a lot of the babies yourself?
Sure. I don't have anything very specific. It certainly is a symptom that's noted usually up until maybe the 4th month of life, and then it seems to dissipate somewhat. And it is one of those symptoms that, again, when we're talking about later onset, like hydrocephalus may reoccur, and it's a worrying symptom if it reoccurs. But as far as really having the mechanism or anything about it, we just know that it is a constant report from the parents, and the babies are hard to console or get to sleep, and it becomes a family concern very quickly.
Thank you, Cindy. We're also going to ask Georgina Peacock. She's one of the leads for this afternoon for the yellow topic session. Georgina Peacock's a developmental pediatrician here at CDC.
And I was recently in Brazil and saw some of the babies that are sort of between about 18 and 24 months, and this is definitely anecdotal, but some of the families were saying that that they saw some calming after seizure medications were started for seizures, and whether or not the crying, some of it was related to seizures or it was the sedating nature of the medicines, we don't know, but that was the same as what Cindy was saying, sort of in that 4 to 6 month time it seemed to subside, and there was some more self-soothing, but maybe some of it was related to seizure activity.
Thanks so much, Georgina.
Hi, Jennifer Bolden-Petrie from National Family Voices. I'm also on the ECHO Zika Task Force as Family Counsel. This question is for Dr. Valencia. You mentioned during your presentation that you work with APNI, which is the family support organization in Puerto Rico that's been in formation for 40 years. And I wondered if you could talk to the importance of working with family support organizations, particularly with these children that are asymptomatic, to that effect.
Yeah. Let me see how I answer that. Yeah, our program is family oriented, and when you have a baby that is born and everything seems to be okay, and then even the pediatrician says to her, don't take it there, the baby is okay, you don't have to be in the developmental surveillance and coordination services. So that was the reason we decided. We have family staff in our program, but we identified the need that we will need a peer that would be a family that already has to go through that, and because of the experience ADNI have, that would be the best way. Not me, the MD, the physician, the system, but other families started, well, we went through this, and this is the reason. So that was the reason we decided the APNI, because APNI have been working with us for long term. So I think having Coral, who is the parent in our staff, makes it, we are planning things, but she is there, and we always ask her, do you think this will work for families? So we are doing that now that they got the grant for optimizing family support from HRSA, so we are working together to maximize. Again, I didn't show it, but can you go back?
Go back.
For example, the numbers I have there is for where the funding came. So mostly the SAPS is being financed through CDC grants. And then on the newborn hearing, the CDC is a new grant, because our follow-up system for babies with that failed the newborn hearing screening doesn't work. So we got a grant, and we are developing a new one that will be easy to be used by the audiologists, so we can get data from then on the results of the audiological evaluations and tracking these babies in the long term that failed the initial newborn hearing screening. Birth defects, we have the original birth defect grant, but then we got another grant in July that we call the enhanced birth defects, and that is for, we are following 51 conditions. Most of them are congenital heart defects, but we got the other grant, and with that grant we were able to expand our services, and that was the grant we used to hire the first service coordinators. So the HRSA 17111 is the optimizing families. We got 2 grants. One that is with APNI, but we have another HRSA grant with early intervention services. Unlike Florida, they move and they change the criteria for being eligible for early intervention services. Our definition still very limited. Okay, so only if you have, the only reason say only infants with congenital microcephaly, they will accept that is what we call high established risk. So families won't have any problem, because what was happening first was that from the hospital they were sending babies to early interventions. They will go through the 45 days. At the end, they would say the families, you're not eligible. So we made them waste their time. So that's the reason we say, refer to us, to children with special. If we identify that the babies are delayed, then we can work in conjunction. I will explain like this. If I have a baby that is born and I have problem with this word, dysphagia, you follow me? So we have the team. We have the nutritionist, we have the OT, we have the speech pathologist, we have the pediatrician. So we can work with that family in the center. But then if the early intervention person comes and see what we are doing, then they can follow with the family at home and work with the family at home and give feedback to the team so we can work together. So really, I wish early intervention revised their criteria for eligibility for services. So we are covering that gap with children with special healthcare needs at this point.
Thank you. Thank you, Dr. Valencia.
One more question. Yep. Hi, Susan Wiley from Cincinnati, developmental pediatrician. I have a quick question. In the children who developed hydrocephalus, were there changes in their head circumference trajectory over time, and is that something that will help us glean the early recognition of that?
The information that we have from the chapter is very limited. Cindy's seen a draft of the paper, and I don't know what you feel comfortable saying. I know that some of the kids did have an increased, I also heard Dr. van der Linden speak about this, so some of the kids did have an increase in head circumference. Some did have irritability and, as Cindy said, changes in their behavior that you would think to do something, but some did have. I'm not sure about the exact numbers, though, and I don't know if you remember those.
Yeah, I don't think we know the numbers, but I think what we heard anecdotally as the typical is that the babies who had a pretty stable head circumference, small, then started showing increases. And that was of course, one of the first signs.
Thank you so much, Cindy. Okay, so, sure, Cassandra, sure.
I'm Cassandra Paisley from Florida Department of Health. I'm Division Director of Children's Medical Services. So we added any baby born with laboratory evidence of Zika as an eligible individual for early steps. So they're eligible from birth to 36 months. But we also added microcephaly as an established condition. We had various other conditions related to head anomalies already on the established condition list. And on an ongoing basis, we look at those conditions that are known to be associated with congenital Zika syndrome and evaluate those for addition to the program as well. The reason why we had individual children who were referred to our program who subsequently were not eligible, which we appreciate, but many of the hospitals, birthing facilities sent all babies to our early intervention program, which is called Early Steps, regardless of the baby's Zika status or whether the babies were symptomatic or asymptomatic. So that's why we got some children referred who were not eligible.
Great. Thank you very much. Appreciate that. Okay, so a couple of people have come up to ask me if these slides are available. So this is live streamed and recorded, so we'll make sure you all get the link for this morning session. The topic sessions are not live streamed or recorded, so I want to reassure you of that. So let me just say thank you for the wonderful questions. Hopefully this morning was useful. Now we're really going to get into the weeds and really begin to think through all of these issues. So really excited and looking forward to this afternoon. Thanks.